Good evening, everybody. Thanks for being with us tonight. So on behalf of the Education and Professional Development Committee, I'd like to welcome you all to today's webinars, which are part of our diabetes mini-series. We will have two sessions tonight. The first is entitled Updates in Diabetes Education, a focus on Sglt2 inhibitors and Glp-1 agonists with our first guest speaker, Dr. Caitlyn Gordon. Dr. Gordon graduated from St. John's University in 2016 and then completed a PGY1 pharmacy practice residency at Long Island Jewish Medical Center. And then she stayed on as her new role as transitions of care clinical pharmacist with their endocrine team. Her practice focuses on patients admitted to LIJ with comorbidities such as diabetes and then also financial and adherence hardships. And she follows up with patients after discharge at medicine specialties at Caitlyn was also awarded first place at Northwell's Patient Experience Conference poster session for her work with patients with comorbidities, as well as multiple awards from Northwell's Pharmacy Service line poster sessions. She's a passionate advocate and enjoys teaching other healthcare professionals the challenges of diabetes management and then also transitions of care. We have our second presentation this evening by Dr. Nicole Albanese, considerations for managing diabetes in older patients. For Dr. Albanese, she is a clinical associate professor at the University of Buffalo School of Pharmacy, and then she serves as assistant director for experiential education as RPD for their PGY2 and AmCare. In 2019, she became certified diabetes educator and education specialist, and in 2011, she earned her board certification as an ambulatory care pharmacist. Additionally, she completed the Academic Leadership Fellowship Program through AACP. In 2011, she had graduated from the Virginia Commonwealth University School of Pharmacy located in Richmond, and then in 2002, she completed a community pharmacy practice residency also at the Virginia Commonwealth University under the direction of Dr. Ralph Small. In her current position, she's involved with the development and implementation of practice care education and research with focuses on diabetes and medication management and a patient-centered medical home physician group. Her current curricular responsibilities, include endocrinology in addition to several other ambulatory care topics and pharmaceutical care, and as well as self-care. She's an active member of our profession and accomplished lecturer and on topics such as diabetes and obesity. She's served as the vice chair of healthcare committee alongside Kim Kelly and in the ACCP endocrine and metabolism PRN for the last 3 years. She's also well published in peer-reviewed journals, textbooks, and casebooks. And without further ado, I'd like to have Dr. Caitlyn Gordon go ahead and take us off for our first session.
Thank you for the introduction. I have nothing to disclose this evening. We'll be using a few abbreviations throughout the presentation, so I've listed them here and on several of the slides. So our learning objectives for tonight are to explain the role of Sglt2 inhibitors and Glp-1 agonists in relation to diabetes management and type 2 diabetes. We'll be describing expanded indications beyond diabetes and updates for these two classes of medications, as well as apply appropriate medication management to patient cases with comorbid diabetes. So just to start off, in order to know where to go with these medications, we have to have a good foundation of the guidelines. So we'll be focusing on American Diabetes Association Standards of Medical Care, and that's updated yearly. And then ACE's Comprehensive Type 2 Diabetes Management Algorithm. So we'll start with ACE. So this was last updated in 2020. If you look at the top, basically it's lifestyle modification and glucose monitoring, and independent of blood sugar control. If a patient has high risk Ascbd or CKD, it's recommended to start an Sglt2 inhibitor and or a long-acting GLP-1 receptor agonist. Additionally, if we go down in the algorithm, depending on the patient's baseline A1C or at the A1C at the time of the visit, it's either monotherapy, dual therapy, or triple therapy, and most of them recommend either GLP-1 receptor agonist or Sglt2 inhibitor, with or without metformin. If we go to the American Diabetes Association, first-line therapy is again focusing on lifestyle modification as well as metformin. However, it also recommends, independent of the baseline A1C, metformin use, or A1C target, to start an Sglt2 inhibitor or a GLP-1 receptor agonist if the patient meets criteria, meaning if they have Ascbd or high-risk indicators, if they have heart failure, or if they have CKD with or without albuminuria. So on the left-hand side, it goes into GLP-1 receptor agonists or Sglt2 inhibitors. Now on the right-hand side, it depends. Unlike ACE, it doesn't really depend on the patient's A1C. It mostly depends on patient-specific and provider-specific goals. So if you would like to minimize hypoglycemia, it still recommends an Sglt2 inhibitor or GLP-1 receptor agonist. If you want to promote weight loss or minimize weight gain, again, these two are some of the first-line options. However, the one criteria it does not meet is cost and access. These are still very expensive, and generics are not available at this time. I also wanted to just point out, while ADA and ACE recommend Sglt2 inhibitors and GLP-1 agonists independent of metformin use, most insurance companies do require a trial of metformin first, or patients have to have a contraindication. And in majority of the cardiovascular trials, about 75 to 80% of patients were on metformin at baseline. So just of note. So if we go into the diabetes medication development timeline, where do these agents come in? So in 2005, exenatide was the first GLP-1 agonist that came out. And then in 2013, canagliflozin was the first Sglt2 inhibitor that came out. And from there, there's been more and more trials, particularly cardiovascular trials. And the reason why these cardiovascular trials came about was because in 2007, rosiglitazone, which is a thiazolidinedione, came out that it was associated with a significantly increased risk of myocardial infarction. So since then, the FDA required that all new anti-hyperglycemic agents had to have cardiovascular safety trials done on their behalf in order to make sure that there was not an increased risk in cardiovascular disease. So these were all designed originally as non-inferiority trials. However, if they did meet non-inferiority, some of the studies were designed for superiority. So the question became, do these study drugs actually lower the risk of MACE? And the primary endpoint in these trials were 3-point MACE, which is cardiovascular death, non-fatal MI, and non-fatal stroke. And it was the composite of those outcomes. So as you can see in 2015 and later, a lot of these trials that we are going to go over in this presentation, EMPA-REG, CANVAS, DECLARE-TIMI, DAPA-HF, these were looking at originally non-inferiority, but because they did meet significance, they ended up being superior to placebo. So we'll start off with the Sglt2 inhibitors, or the sodium glucose cotransporter 2 inhibitor. And these all these generic names end in flozin. So canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. So this is a tubule. So approximately 180 grams of glucose is filtered per day. And normally 90% of it gets reabsorbed by Sglt2. So that, again, it helps reabsorb sugar. However, what the drug manufacturers have decided to do was to inhibit this protein in order to make sure that the sugar does not get reabsorbed, but rather gets excreted in the urine. So again, these medications help increase the urinary excretion of glucose. And just to give like a wide overview about their advantages and adverse effects, so efficacy-wise, as a class, they lower A1C a little bit less than 1%. They do have some weight loss benefit, up to 3.3 kilograms. It is a low risk of hypoglycemia, and then some of the medications, which we'll go more specifically into, have long-term cardiovascular disease benefits, long-term CKD benefits, though it is dependent on the individual medication. And all of them help reduce heart failure hospitalizations with heart failure with reduced ejection fraction. One exception, ertugliflozin, it was not powered for statistical significance, but it did show a positive trend towards reducing heart failure hospitalizations. In terms of adverse effects, as a class, these medications can cause mainly genital mycotic or fungal infections of the GU tract. It's questionable, and we'll go into about UTIs and bacterial infections. It can cause renal insufficiency, particularly due to hypotension and volume depletion. There's an increased risk of euglycemic DKA, particularly during surgery. So it is recommended to stop these medications about 3 to 5 days prior to planned surgeries. With canagliflozin, previously there was a black box warning that it caused lower limb amputations. That has since been lowered to just a warning, but it's still a pertinent warning for patients who are at risk. Some other special considerations is renal dose adjustments, which we'll go into more specifically. It actually depends on the indication. And at lower eGFRs, most are not effective for blood sugar control. They're only effective for those secondary benefits like CKD progression. Additionally, they're very high cost, as we mentioned before, without insurance. So going into the genitourinary infections, most commonly it's fungal infections, so genital mycotic infections, and that is usually the species Candida. Some risk factors associated with it are being female, history of infection, uncircumcised males, or just poor genital hygiene. And the mechanism is thought to be due to altered immune function, due to increased urination of sugar, and altered microflora of the genital region. There's a lot of mixed evidence in the last few years regarding risk of UTI or severe UTIs. There's been multiple studies that haven't shown an increased risk, and then rarely Fournier's gangrene there's been some case reports about this occurrence, but it is a rare occurrence. When we look at patients who are on Sglt2 inhibitors and as well as concomitant diuretics and hypotension, there's one mostly an expert opinion article that kind of goes over what to do when you have a patient on diuretics and if you have a patient with baseline hypotension, because these medications can lower systolic blood pressure by about 3 to 5 millimeters of mercury. So at baseline, if a patient is hypotensive, if they're hypovolemic, it's recommended don't start an Sglt2 inhibitor. You want to look at underlying causes and additionally adjust medications or even stop diuretics as necessary. If the patient is normotensive, they're euvolemic, and if their age is over 65 years old, you should start the Sglt2 inhibitor, but consider reducing the diuretic dose by 50%. And the reason for that is because, again, this class of medications is expected to, again, have the diuretic effect and lower blood pressure. And additionally, if you keep the diuretic the same as well as add this class of medication, the patient may be at risk of hypovolemia as well as hypotension. And lastly, again, this is all based on like an expert opinion article by Gomez Peralta, as well as Uma Pierres. And if the patient's hypertensive and hypervolemic and their age is less than 65 years old, it's recommended, don't adjust any of the other medications and start the Sglt2 inhibitor and then adjust as needed. With this same article, they also give some guidance as what do I do if I also have a patient on insulin or an insulin secretagogue. So this one is, again, expert opinion until we have more concrete evidence out there. But if the patient's A1C is less than 8.5%, it's recommended, so SU is significant for sulfonylurea, so either decrease the sulfonylurea or meglitinide by 50% or stop it. Decrease rapid-acting insulin by 10 to 20%. If a patient's only on basal insulin, decrease by 10 to 20%. The most important point being is do not stop insulin abruptly due to the risk of Glycemic Dka. So again, this is expert opinion. It is not written in stone to do these changes. If the patient's A1C is greater than or equal to 8.5%, then these authors recommended continue medications and adjust as needed. So another effect of this class of medication is initially within the first 2 to 4 weeks, there's a decline in the eGFR by about 3 to 6 milliliters per minute. And you can see with that magnifying glass, that drop is pretty significant. However, it does even out by about week 12, and eventually by 1 year, it crosses over and stabilizes. But again, the first 2 to 4 weeks, there is a drop in the eGFR, and it recovers around week 12, and then there's attenuation of the eGFR slope around 1 year. So the risk factors for this initial GFR decline is if a patient is hypovolemic, if they're on diuretics, if they're on ACE inhibitors, ARNIs, or ARBs, they're on NSAIDs, or if they have heart failure. So the study that I pulled this chart from is actually based on Credence, which was done for canagliflozin, and it's a prediction of what would happen if a patient is on RAS inhibitor, so if they're on an ACE or an ARB versus if they're on an Sglt2 inhibitor. Again, these studies haven't been out for 15 years, but this is just a prediction that if a patient was to remain on an Sglt2 inhibitor, the decline is about 1.85 per year based on credence, versus if they were to remain just on an ACE or an ARB, the decline in eGFR is about 4.6 milliliters per minute per year. And if theoretically, if you were to remain on an Sglt2 inhibitor, you could prolong becoming, dialysis dependent by an additional 15 years. So you can prolong end-stage kidney disease if a patient was to start an Sglt2 inhibitor. And again, this is theoretical, and it comes from the Credence trial based on the decline per year in renal function. So it's just interesting that we haven't had any other medications besides ACEs or ARBs that help preserve renal function, and now we have this class of medications that could potentially provide an additional 15 years free from end-stage kidney disease. Another rare but serious side effect is euglycemic Dka with this class of medications. So mechanistically, it's thought to be due to, so on the left-hand side, you see the kidneys, and it actually may increase ketone body reabsorption. So one mechanism is thought to be due to reabsorbing more ketones. The other is due to increased ketone body production. So the reason for that is as the body is excreting more and more sugar, the pancreas is not releasing as much insulin, so there's less insulin secretion. Normally what insulin does is it helps inhibit lipolysis, so it actually helps, so it stores fat rather than break it down. When there's less insulin secreted, now there's an increase in lipolysis, and with increased lipolysis, there's more free fatty acids, and free fatty acids get oxidized in the liver and produce ketones. So again, these twofold mechanisms of increased ketone body production and reabsorption from the kidneys may potentiate euglycemic Dka. Now, it doesn't occur in everyone. It is a rare side effect, but it could be precipitated by surgery, by myocardial infarction, severe infection, prolonged fasting, dose decreases in insulin, and alcohol abuse. So if this does occur in a patient, the recommendation and the consensus is to discontinue the agent. So just to summarize the advantages before we go more specific into them. So I have the four main Sglt2 inhibitors on the left. For type 2 diabetes, I have the eGFR cutoffs, meaning that above this cutoff is where they're effective for diabetes. So you can see canagliflozin and empagliflozin, they're effective up to a eGFR of 30 or higher, whereas dapagliflozin and ertugliflozin are only effective for diabetes up to an eGFR of 45. So that's pretty significant. In terms of Ascbd benefit, only two have the benefit as an FDA label based on their CVOT trials, so canagliflozin and empagliflozin. Dapagliflozin, I have that little symbol because it didn't meet it met inferiority. It only met superiority for a secondary outcome, and that was to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes and established cardiovascular disease. It was not inferior in terms of 3-point MACE. So it does not have that Ascbd label. It does help reduce the risk of hospitalization for heart failure in patients with Ascbd. And then ertugliflozin was not inferior. So there's a big X there. For diabetic kidney disease, canagliflozin and dapagliflozin do have the FDA label to help slow the progression. And with Farxiga, it is with or without diabetes. And then heart failure with reduced ejection fraction. Just to go back for diabetic kidney disease, for empagliflozin, so this medication, it hasn't been shown in it hasn't been a primary outcome trial, it's only been in secondary outcomes. And with that, the data is a little bit, it's not concrete. So we're still waiting on a larger trial for diabetic kidney disease. For heart failure with reduced ejection fraction, it's thought to be a class effect. The reason I put a question mark with ertugliflozin is because it was not tested for statistical significance. So I just have that. It was, in a sense, it was more effective than placebo, but it did not meet statistical significance. With empagliflozin and dapagliflozin, those did meet significance for the heart failure with reduced ejection fraction trials in those with or without diabetes, and canagliflozin was a secondary outcome trial. And then for heart failure with preserved ejection fraction, it's only empagliflozin with or without diabetes. And then renal dose adjustments. I have this here for reference, just in case anyone is interested. I'm happy to share the slides. But there's much different cutoffs depending on the indication, and some of it is off-label. The two I just want to focus on are dapagliflozin. So that one, up to an eGFR of 25 for ASCVD, for diabetic kidney disease and heart failure with reduced ejection fraction. However, less than 25, you may continue it, but it's not recommended to start it. And again, it does not have that ASCVD indication. It's only to reduce the risk of hospitalization for heart failure in patients with ASCVD. And then empagliflozin for diabetic kidney disease up to an eGFR of 20. Same with heart failure with reduced ejection fraction. Okay, so going a little bit more deeply into the ASCVD study. So EMPA-REG for Jardiance and Canvas for Invokana. So if you can see the left-hand side for EMPA-REG, it's with type 2 diabetes with established cardiovascular disease. So large trial done over 3.1 years at both doses, 10 or 25 milligrams. And it did meet the primary endpoint for statistical significance by lowering 3-point MACE by 14%. It also showed secondarily that it helped lower heart failure hospitalization. So this was before Emperor reduced, which was the heart failure trial. In Canvas, or for canagliflozin, this was type 2 diabetes, as long with included patients with risk factors as well. And this was, again, another large-scale trial done over 3.5 years, and it helped lower 3-point MACE by 14% as well. Additionally, it helped lower composite renal outcomes by about 40%. So that's significant and kind of helped led to the next trial of Credence, which is for the kidney outcomes. If we go to the other two trials, Declare-TIMI and Virtus-CV, this was for dapagliflozin and ertugliflozin. You can see primary endpoint was non-inferior. For dapagliflozin, cardiovascular death or heart failure hospitalization did show significance. It was mainly driven by heart failure hospitalization. Additionally, renal outcomes for Farxiga were lowered by 24%. However, for ertugliflozin, renal outcomes were not statistically significant. And again, those heart failure hospitalization, it lowered it, but statistically it was not tested. So this is just the outcomes from EMPA-REG and Canvas. So as you can see, both of them showed 14% relative risk reduction compared to placebo for 3-point MACE, which again is CV death, non-fatal MI, or non-fatal stroke. And the separation happens pretty early if you look at empagliflozin's chart. If we look at ASCVD outcomes in Declare-TIMI and Virtus-CV, you can see non-statistically significant. But they were non-inferior. Okay, now going into the heart failure studies. So these are heart failure with reduced ejection fraction. If we look at dapagliflozin, it studied patients, actually both of them, empagliflozin and dapagliflozin. It's with or without type 2 diabetes and a heart failure with reduced ejection fraction of 40% or less. It was about, both of them were 16 to 18 months in length, and they only studied the 10 milligram dose. About half of the patients or less had type 2 diabetes, and both of them met primary endpoint for statistical significance. And then if you can see for empagliflozin, there was a slower rate of eGFR decline. So eGFR declined by 0.55 versus placebo was negative 2.28 per year. And again, it was a short follow-up, only 16 months, but that was statistically significant. If we look at the secondary outcomes for some of the other trials for canagliflozin, you can see in both Canvas and Credence, there was 33 and 31%, like 33% heart failure hospitalization reduction in Canvas and 39% heart failure hospitalization reduction in Credence. And then Virtus-CV, again, 30% relative risk reduction, though not tested for statistical significance. And then these are just the two primary outcome graphs. And again, they studied slightly different primary outcomes, and I have them listed here. For DAPA-HF, it looked at also urgent care visits resulting in IV therapy for heart failure, along with death from CV causes and hospitalization for heart failure. And you can see the graphs separate pretty early on in both instances, and they lowered it by about 26 and 25% respectively. For the secondary heart failure outcomes in Canvas and Credence and Vertis-CV, I have them listed here. And again, they don't have the FDA label for it, but it is expected to be a class effect, again, because of the diuretic effect of SGLT2 inhibitors. Then we go to Emperor Preserve, which is empagliflozin's heart failure with preserved ejection fraction. So this studied patients with an ejection fraction greater than 40% with or without diabetes. It was a large sample size. They studied the 10 milligram dose over a course of about 26 months. And the primary endpoint was significant. It lowered the composite of CV death or hospitalization for heart failure by 21%. This was mainly driven by heart failure hospitalizations. And secondarily, there was a change in the mean eGFR slope per year, negative 1.25 versus negative 2.62. However, the composite renal outcome was not statistically significant. So that's why I had mentioned before for Jardiance, although it does change the slope in the eGFR, there needs to be a larger outcome trial for renal outcomes in order to determine if it does have the same effect as dapagliflozin and canagliflozin. So that leads us into the diabetic kidney disease / CKD trials. So if you look at the top for canagliflozin and dapagliflozin, it studied patients with eGFR about 30 to 90 for Cana and 25 to 75 for DAPA, with urine albumin to creatinine ratio 300 to 5,000. And then for DAPA, it's 200 to 5,000, and they include with or without diabetes. So that's why we have, it doesn't just say diabetic kidney disease, it's also CKD in this patient population. They studied patients for about 2.5 years and both met statistical significance. So for canagliflozin, it was looking at end-stage kidney disease, doubling of serum creatinine, or renal or CV death. And then for dapagliflozin, it was composite of sustained decline in eGFR of at least 50%, end-stage kidney disease, or renal or CV death, and that lowered it by about 39%. And then we only have the secondary outcomes for the other trials. For ertugliflozin, renal outcomes were not statistically significant. And in empagliflozin, we do see slower rate of eGFR decline. However, there needs to be a larger trial to determine if renal outcomes are statistically significant, since we saw in Emperor Preserve, the renal composite outcomes were not statistically significant. So if you look at the chart here, on the left is Credence for canagliflozin. It was a 30% relative risk reduction, and for DAPA, it was a 39% relative risk reduction. And they do have slightly different primary endpoints, which I did mention before. Then if we look into a little bit deeper screening by the eGFR and albuminuria, the top is canagliflozin, and it only had significance between eGFR of 30 to 60. When it was 60 to 90, it crossed that hazard ratio of 1 and did not have statistical significance. Same with baseline urine albumin to serum creatinine ratio. It was only above 1,000 where it showed statistical significance. So that's just an interesting point to note. For dapagliflozin, it was actually at all eGFRs and at all urine albumin to creatinine ratios where it fared better than placebo. So just an interesting note between the two. Again, it's not head-to-head, they were both versus placebo. And if we look at the diabetic kidney disease and CKD secondary outcomes, you can see with empagliflozin, there's that initial decline of about 4 in the first 2 to 4 weeks, and eventually it does even out. You get to week 76 and then eventually does better than placebo, which is very common for the SGLT2 inhibitors. And then in Vertis-CV, you can see that there was no statistical significance with renal composite outcomes. And just a quick, it would be remiss if I didn't talk about the new heart failure updates. So they did add SGLT2 inhibitors a little while ago for stage A heart failure, which is primary prevention for those patients at risk of heart failure. It recommends any patient with type 2 diabetes and either cardiovascular disease or high cardiovascular risk. They should be started on an SGLT2 inhibitor. It doesn't specify which one. They just kind of say any SGLT2 inhibitor. Patients with stage C heart failure with reduced ejection fraction, EF less than or equal to 40%, it's actually recommended to start simultaneously or in sequence an SGLT2 inhibitor. So that's a change in previous guidelines, which was normally in sequence. You try one, then you try another. This you could kind of start at the same time. And additional category of heart failure with moderately reduced ejection fraction, they recommend an SGLT2 inhibitor, though it's a 2A recommendation. And then heart failure with preserved ejection fraction, which is an EF greater than or equal to 50%, they recommend an SGLT2 inhibitor may be beneficial in decreasing heart failure hospitalizations and cardiovascular mortality. They do not specify that the only trial is empagliflozin, but that is the one that we would recommend. So just time for our first polling question. So we're gonna go like case by case because I think that's just the best way to kind of apply the knowledge. So there's a 65-year-old male with past medical history of CKD, EGFR 50, urine albumin to creatinine ratio 342, heart failure with reduced ejection fraction, EF of 30%, type 2 diabetes with an A1C of 8.4%, and history of coronary artery disease, status post 1 stent, presents to the office for wellness exam. He's on metformin 500 twice a day, aspirin 81, metoprolol succinate 50, atorvastatin 40, furosemide 20 twice a day, and lisinopril 10 milligrams daily. So which additional medication would you add on? We'll just give a minute or so. Great. Majority of you guys said Farxiga or dapagliflozin, 10 milligrams daily. Very good. And the reason for that is the patient has heart failure with reduced ejection fraction. We know that it helps reduce heart failure hospitalizations. He does have diabetic kidney disease with albuminuria, and he has type 2 diabetes. And at that GFR, it is still effective for type 2 diabetes. The one thing I also want to note is we don't know everything about this patient, but if his blood pressure is running on the lower side, depending on his volume status, we may want to consider lowering the furosemide dose when we start and initiate this medication. So just the next polling question, the same patient 8 years later now has an EGFR of 40. Dapagliflozin should be stopped because it is no longer effective for preventing diabetic kidney disease or heart failure hospitalizations. True or false? We'll just give a minute. And correct. Majority of you guys said false. So it's no longer effective for blood glucose control. That's kind of the point of this question. So dapagliflozin is no longer effective at an EGFR less than 45. But for diabetic kidney disease and heart failure, you can actually continue up to an EGFR of 25, and some people will even go up to 20. All right, so now we're going to switch gears into the glucagon-like peptide, or the GLP-1 agonist. So this is a list of majority of the GLP-1 agonists on the market. We're going to be focusing on just a few: dulaglutide or Trulicity, liraglutide, Victoza, as well as semaglutide, Ozempic, as well as Rybelsus, and then the new one, tirzepatide, Mounjaro. So in terms of the mechanism of action, GLP-1 is a incretin hormone that gets secreted in the gut in response to food. So in response to food, it tells the body to enhance insulin secretion by the beta cells, stop inappropriate glucagon secretion in the alpha cells of the pancreas. It helps slow gastric emptying and reduce the food intake. So it does a few different mechanisms to help lower the blood sugar. So just kind of an overview of what it does, some advantages. Advantage-wise, A1C reduction is pretty significant, up to, actually now up to over 2% with the newest one, tirzepatide. Weight loss is pretty significant. It's even more so than that 1 to 4 kilos now with the newer agents, and up to, we'll go into that a little bit more, but weight loss can be really significant at higher and higher dosage. It can help lower blood pressure, can help lower triglycerides. It helps improve markers for beta cell function. And then there's ASCVD benefit for some medications in the class, which we'll go into. There is a black box warning. It's contraindicated in any patient with a history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. It's never been proven in humans, but there was rat or mice models that showed that it could cause this. GI effects can be pretty significant. It can increase lipase, which is not good. It can cause significant abdominal pain, nausea, and diarrhea. There's a mild to moderate risk of hypoglycemia, particularly if patients are on insulin or insulin secretagogues. There's this questionable increased risk of acute pancreatitis, which we'll go into. It could potentially worsen retinopathy for 3 of the medications in the class. And they do, as a class, slow gastric emptying. So we want to avoid in patients with gastroparesis. Additionally, the nausea and vomiting are typically transient, but it can be worse with daily injections. So the weekly injections are a little bit more tolerable. But not every patient, it has to be patient specific. You want to make sure the patients are eating small, not fatty meals. And then on dose adjustments, like dose increases, we just want to be careful because that's when side effects tend to present. So going into the retinopathy risk, for dulaglutide, Trulicity, exenatide, Bydureon, and semaglutide, Ozempic, warnings were added to the package inserts because the rates of retinopathy were worse compared to placebo, and those were in the cardiovascular trials. However, there was a large meta-analysis done last year which showed no significant association between GLP-1 agonists and retinopathy risk. However, a meta-regression showed a significant association between A1C reduction and retinopathy. So the thought is that the larger the A1C reduction, that's what's actually driving the retinopathy worsening risk. And the time frame is very variable, from 3 months to 3 years being on this medication. So it may not be the medication itself, but rather the A1C reduction. Currently, semaglutide or Ozempic, there's a large-scale trial going on to look at retinopathy risk. So hopefully once that trial is completed, there'll be a little bit more information on this risk of retinopathy. But this meta-analysis and meta-regression did show that it was mainly due to the A1C reduction worsening retinopathy, which is something we've known for a while in other trials. Now for the pancreatitis risk, this first came out in 2013. There was a case control study that showed that exenatide had an increased odds of hospitalization for acute pancreatitis. However, since then, there's been a lot of large meta-analyses which has showed no increased risk of pancreatitis, but an increased risk actually with the DPP-4 inhibitors, so a different class of medications. And you can see that with this chart, it completely is crossing 1, where there's no increase or decrease risk. So still a lot of endocrinologists that I work with, if patient has a significant history for pancreatitis, they will choose to hold off on this medication due to the various case reports. However, again, the large meta-analyses kind of give a little bit more comfort, showing that there hasn't been shown to be an increased risk. So just to summarize the advantages, all of them as a class promote weight loss and lower blood pressure. And in terms of ASCVD, so reducing the risk of cardiovascular events, dulaglutide, Trulicity, liraglutide, Victoza, and semaglutide, Ozempic are the only ones in the class that have reduced 3-point MACE in trials. Exenatide ER and semaglutide Rybelsus have been shown to be non-inferior. Okay, so to go in specifically to those three main medications, dulaglutide is the only medication that has the FDA approval for both primary and secondary prevention of ASCVD. So this could be used in patients with multiple cardiovascular risk factors, as majority of patients in the trial actually did not have ASCVD, they had risk factors. The titration schedule is shown here. You want to titrate every 4 weeks up to a dose of 4.5 milligrams weekly, and increase A1C reduction and weight loss the higher the dose. And it's really dependent on the patient, depending on what they can tolerate. One interesting study that the drug company performed was that after training patients, their willingness to use an injectable medication was 94%. So a lot of providers may kind of avoid GLP-1 agonists unless it's Rybelsus. But I think once patients are shown how to use it and are taught and use TeachPack, I think this is a good indicator that it may be a viable option, especially if patients have these risk factors for ASCVD. For liraglutide Victoza, this is FDA approved to reduce the risk of MACE in adults with established ASCVD. It's also approved for type 2 diabetes at younger age, so age 10 and older, so one of the few medications you can use. The dosing schedule is every 7 days. This is a daily injection. The original starting dose is not effective for diabetes. It's solely to help the patient get used to tolerating the GI effects. And all of the doses are on that single pen. And then we go to semaglutide or Ozempic. It helps reduce the risk of MACE in adults with type 2 diabetes and established ASCVD. There's a new dose. The dosing schedule is weekly. Every 4 weeks, you can increase the dose up to 2 milligrams weekly, which is a new dose. And that helps lower A1C by 2.1% with a 14.1 pound weight reduction. And then Rybelsus is the oral option. This is not indicated for ASCVD. It was shown to be non-inferior in MACE outcomes. And this one, because it is a protein, it's a very, very low bioavailability. It needs to be administered 30 minutes before food, beverage, or other medications. You can only have 4 ounces of drink to swallow the pill. The 3 milligram dose, similar to liraglutide and Ozempic, it's not effective. The lowest dose is just to tolerate the medication. And then the titration is every month, up to 14 milligrams a day. So the ASCVD trials are shown here, and I only included the ones that had that were superior. So for liraglutide, semaglutide, and dulaglutide, you can see the sample size, 83% had ASCVD in the first 2 trials, and then for Trulicity or dulaglutide, it was only 31% that had ASCVD. So that's where the FDA approval comes from primary prevention, since most of the patients had 2 or more risk factors. And the 3-point MACE reductions was 13, 26, and 12% respectively. And they were done over different time frames. The first trial was done over about 4 years, second trial 2 years, the last trial was 5 years. Just of note, some notable secondary outcomes is in the renal and retinal outcomes. So for liraglutide, there was a 16% reduction in the composite of renal and retinal outcomes. This was mainly driven by the renal outcomes. For semaglutide, 36% lowered the risk of new or worsening nephropathy, so kidney outcomes, but it did increase retinopathy complications, and this is where that warning first came about due to this trial. And then with dulaglutide, it showed a 15% composite renal outcome, which is significant. In all of them, there was no significant difference in heart failure hospitalizations. So this is just showing primary outcome 3-point MACE for liraglutide, 13% relative risk reduction, and then death from cardiovascular causes was the main driver, and that was a 22% reduction. If we go to semaglutide, the main driver in 3-point MACE was actually due to non-fatal stroke, and you can see this is the only one that was statistically significant out of all of the other composite outcomes. Or out of all the individual outcomes that made up the composite of 3-point MACE. And the same with dulaglutide. With the 3-point MACE, it was statistically significant, and that was really driven by non-fatal stroke. So if we look closer at the renal and eye outcomes, so this is for liraglutide, nephropathy actually was statistically significant. For dulaglutide, the renal outcomes, again, statistically significant. And then for semaglutide, for nephropathy, newer worsening, statistically significant, and then retinopathy complications was the only one that was statistically significant out of all of them. So going into the combination GIP, GLP-1 agonist. So GIP is glucose-dependent insulinotropic polypeptide. What this does is help increase glucagon while a patient is fasting or if they're hypoglycemic, and helps promote insulin release when their blood sugar is high. So one of the main notable differences between the GIP/GLP-1 agonist combination and just GLP-1 alone is it actually has a direct effect on increasing insulin sensitivity, which is huge. With the GLP-1 agonist, it is thought to increase insulin sensitivity, but indirectly due to weight loss. So the combination of GIP with GLP-1 actually directly helps increase insulin sensitivity. So now just going into SURPASS-2, which is the trial for tirzepatide, and this was versus Ozempic 1 milligram. So on the bottom left chart, at all of the doses tested, 5, 10, and 15 milligrams, it was statistically significant compared to Ozempic 1 milligram in lowering A1C reduction. So on average, about over 2%. With weight loss, this was even more significant. So again, versus Ozempic 1 milligram, the lower dose 5 milligrams had about 17-pound weight loss, the 10 milligram dose about 20-pound weight loss, and 15 milligram dose about 25-pound weight loss compared to 13 pounds for Ozempic 1 milligram. So this is, again, a new agent that just was FDA approved. It does not have cardiovascular outcome trial data just yet, but it does have significant benefits for patients with type 2 diabetes in terms of weight loss and A1C reduction. And this is just the dosing schedule. There are several doses and dosing titrations, and it is weekly. Every 4 weeks you can increase the dose. The other notable effect that is just interesting for this, it's not a class effect just in this one, is that it may decrease the serum concentration of hormonal contraceptives. So especially after 4 weeks after initiation and 4 weeks after every dose increase. So that's just something new. They think it may be due to the gastric emptying effect, but not completely sure. And then again, just kind of stepping out of the GLP-1s for type 2 diabetes, but actually the indications for weight loss, we have liraglutide, marketed as Saxenda, which is in combination with diet exercise with BMI over 30 or BMI greater than 27 with comorbidities. It's also indicated for kids for ages 12 and up with certain criteria. And this goes up to, unlike Victoza, which only goes up to 1.8 milligrams, this goes up to 3 milligrams daily. And it showed 8% change in body weight. And then about 2/3 of patients lost about 5% of their body weight, and about 14% of patients lost 15% or more of body weight. The other medication, semaglutide, marketed as Wegovy, has even more significant effects. It wasn't a head-to-head trial, again, just due to versus placebo, but it did show 14% change in body weight on average. And then majority of patients lost 5% or more of their body weight. So that was 86% lost that. And for patients losing 20% or more, that was about a third of patients. So this was even more significant. And this is a weekly injectable. So it's a little bit more convenient than daily with better outcomes. Again, not head to head, but just versus placebo. So again, kind of just to wrap up, deciding between an SGLT2 inhibitor and a GLP-1 agonist. If you're looking for more weight loss for a patient, GLP-1 agonist is going to be more significant, more A1C reduction, GLP-1 agonist. If you want to prevent hospitalizations for heart failure with reduced ejection fraction, SGLT2 inhibitor. Slow the progression of chronic kidney disease, SGLT2 inhibitor would be preferred. Lower blood pressure as well. For ASCVD, it's really drug specific based on the ones we talked about today. Now, if you have patients with a past medical history of gastroparesis or pancreatitis, uncontrolled diabetic retinopathy, it may be better to choose an SGLT2 inhibitor. A patient with extreme needle phobia, either Rybelsus or an SGLT2 inhibitor. And then if you have a patient lower blood pressure, hypotension, or recurrent genital mycotic infections or UTIs, GLP-1 agonists. So just to go into this next few polling questions, we have a 48-year-old female with type 2 diabetes who walks a mile every day, does exercise classes, is very interested in losing weight. She has limited food choices. Her past medical history is hypertension, at goal, and hyperlipidemia. BMI is 38. Her A1C is 9.2%. She's only on metformin for diabetes, atorvastatin, losartan, and aspirin. So the question is, in choosing an additional diabetes medication, what additional effects would you want from the medication? And great, majority of everyone said both B and C. So with this patient, again, she is interested in losing weight. Her BMI is 38 and her A1C is uncontrolled at 9.2%. So we really want those two factors to be taken into consideration when we're choosing a medication. So a follow-up to that is, which diabetes medication would provide the greatest benefit for our patient? Would it be semaglutide, pioglitazone, glimepiride, or canagliflozin? And great. I mean, there's two right answers, but there's one that's more right, and that would be A, semaglutide, starting at 0.25 milligrams weekly and titrating up. Reason for that is it, again, both would be acceptable, but to get the most weight loss and the most A1C reduction, Ozempic or semaglutide would be the best answer for this patient. I just kind of, again, there's no head-to-head trial of the two, but you can just see greater weight loss and greater A1C reduction. So a new case, we have a 65-year-old male with type 2 diabetes for 8 years. He recently had a heart attack with 2 stents placed. His ejection fraction is 25%. His blood pressure is uncontrolled. His eGFR is 45 with positive urine albumin to creatinine ratio greater than 300. His BMI is 22 and his A1C is 7%. So this one's more of a choose all that apply, because we have a lot of different things to consider. So in choosing a diabetes medication, which additional effects would you want? Would you want greater A1C reduction? Would you want weight loss? Would you want blood pressure control? Would you want to slow the progression of nephropathy? Would you want to prevent heart failure hospitalization? And would you want to prevent future MACE events? So again, there's more than one right answer. Okay, good. So I'll just go one by one. We don't really need greater A1C reduction. His A1C is pretty much at goal, 7%. We don't need weight loss. His BMI is 22. I didn't provide the weight, but we do need all the other factors. So we do want blood pressure control if he's uncontrolled. We do want to slow the progression of nephropathy. He does have an eGFR of 45 with positive albuminuria. We do want to prevent heart failure hospitalization. His EF is 25%. And we do want to prevent future MACE events as he just had a heart attack. So now, putting it all together, which diabetes medication would provide the greatest benefit for our patient? Rybelsus, semaglutide, Jardiance, empagliflozin, pioglitazone, or Lantus? And good, majority of you guys said B, Jardiance. And we'll go into why that is. So basically, if you were to choose empagliflozin, you'd get Ascbd protection. You'd prevent you could potentially prevent heart failure with reduced ejection fraction hospitalization. It'll help improve the blood pressure. And again, more trials are necessary, but it may help slow kidney decline pending larger studies. Rybelsus, on the other hand, it does not have any Ascbd protection. It does not prevent heart failure hospitalization, and it does not help slow kidney decline. So that's why the best answer would be empagliflozin. And then last question, we have a 48-year-old female with type 2 diabetes, hypertension, hyperlipidemia, obesity, BMI 32. Her A1C is 8.9% on metformin and Januvia. We want to start Trulicity with the patient. What should you verify before starting? So A, Januvia should be discontinued, yearly ophthalmology exam, insurance coverage, history of pancreatitis, or all of the above. And good. So mostly said all of the above. So whenever you're starting a GLP-1 agonist, we shouldn't be using it with a DPP-4 inhibitor. Excuse me. You want to make sure that they have a yearly ophthalmology exam, make sure we don't have any uncontrolled retinopathy, insurance coverage, and then any history of pancreatitis or risk factors for pancreatitis. You also want to verify the patient doesn't have a history or family history of medullary thyroid cancer or personal history of gastroparesis. I also wrote that on the side. And that concludes this first presentation. Thank you for bearing with me. I am a bit under the weather today, and I'll be happy to take any questions at this time.
Go ahead and throw any questions you have in the Q&A session, please. And thanks, Caitlyn, for powering through. I know you weren't feeling well tonight. One question that there is right now, is there any data that exists to support the combination of SGLT2s and then GLPs to improve either cardiovascular or renal outcomes, and using them concomitantly for patients?
Yeah, so I think data is pretty limited, but we do have a lot of providers who are utilizing both. Hopefully there'll be more large-scale data to support it, but you might as well, if you have two classes of medications that have not all of them, but some of them have 3-point MACE reduction, heart failure with reduced ejection fraction, diabetic kidney disease. It would be a good thought to use both, especially in patients that are higher risk for having these secondary events. And to my knowledge, I'd have to look into it. I don't believe there are large scale trials out there just yet, besides like, case reports, case series, and then anecdotally using both in patients. But I think that would be a fair, a really good idea to use them in certain high risk patients.
Got it. Thank you. And then let's see here. And then another question I think the last time when we have for us time is, if you had to pick one out of each of these classes that you spoke about, which one would you choose and why? Maybe that's probably a big question, but I don't know if you can provide any guidance, I guess, picking between the different GLP-1s that have, our benefits, and then also the SGLT2s, if any preference for that matter.
Yeah, I wouldn't say I have any like favorite that I would pick. I think it really depends on the patient, and with the patient, the provider making a decision, what would be best for them. And looking at the comorbidities, looking at, do you want weight reduction? Do you want blood pressure control? Looking at any maybe side effects that they have, and really making it as patient specific as possible. Within the class, I don't have like anyone that I would choose. If you have, for example, you're looking for Ascbd reduction, the patient never had an Ascbd event, but they have risk factors like smoking, overweight, I would choose like Trulicity, because that one has shown to have primary prevention. So I don't have, specific ones that I would choose over the other, but I think it really comes down to patient specifics, patient preferences, and then what are you really looking for? I hope that helps.
Got it. Yeah, thank you. So I think that's all the time for questions we have right now. There was another question about ASCVD risk protection. So the handout, the PowerPoint will be available as a handout following the program. So you'll be able to find that there. I believe there was a table or two that summarize that. And then if you look in the chat, the CE codes for session 1 are available. So the codes for session 2 will be made available later. I'll go over those, but if you look in the chat, session 1 is available. And then I would like to go ahead and turn it over now to our second speaker, Dr. Nicole Albanese, and then for her program, Considerations for Managing Diabetes in Older Patients. All right, and then Dr. Albanese, I see your presentation, so I think you're good to go.
Great, thank you so much.
Yeah, sure.
Okay, so welcome everyone. Thanks for sticking this out. It is 8 o'clock at night. So I'm going to be talking about how we can help manage diabetes in our older patients. And this is the new PC term to be using. They're not called senior citizens. They're not called elderly. They are supposed to be called older adults. I am Nicole Albanese. I'm from the University at Buffalo. And Caitlyn already did a great job of introducing a lot of concepts that I'll talk about, namely the fact that within diabetes, if you practice at all in making recommendations surrounding diabetes, you know that there are two main guidelines which get confusing. We have ADA that puts out guidelines every year, and we have ACE, which put guidelines out every few years whenever they feel like it. And so that can get confusing, not only for us, but for providers. So ADA has the most robust information about older patients. So that's really where I'm going to focus on tonight, and where I've pulled most of my information is from ADA guidelines. And frankly, when I teach this information to the pharmacy students at UB, I sort of have them look at these guidelines like ADA is meant for people where you want to have looser type goals, and ACE is sort of meant for patients where you want to have super tight, strict goals. So these are our learning objectives for tonight. We're going to talk about management and goal setting. We're going to talk about cardiovascular risk modification. And then we're going to talk about hypoglycemia. And frankly, I'm probably going to talk about hypoglycemia throughout the entire presentation, because that really should be your mantra when thinking about dealing with older patients is avoiding hypoglycemia at all costs. So let's quick talk about some epidemiology, but specifically in older adults. So some of the numbers that you see here are a little bit dated. They're from 2019, so I'd expect these to be even higher. But in patients who are over the age of 65, nearly a third of them have diabetes, and nearly half of them, so 50%, have pre-diabetes. And as you would expect, they delineate some things that are more likely to be seen, whether you've been diagnosed before the age of 65 or after the age of 65. And this sort of makes sense as you think about them. So the earlier you're diagnosed, the more likely it is that your A1C will be higher. More likely it is that you'll end up on insulin as an older patient, and complications are more common, notably retinopathy. But if you can prevent diabetes until well after 65, you tend to not be on insulin and have a lower A1C. So this sort of tells us that we should spend some time and focus on prevention and delay of diabetes, capturing our patients as pre-diabetics and getting them on therapy and lifestyle modifications to ensure that they don't progress to full diabetes too quickly. Continuing with some prevalence, unfortunately, our older adults do have the highest rates for certain comorbidities, and those rates increase even more with age. In fact, over the age of 75 has the highest rates for all of these things you see here in terms of amputation, MI, visual impairment, and renal disease. And then shockingly, you can see, but maybe it's not shocking, especially if you work in a hospital system, that patients over the age of 75 double the rate for ED visits related to hypoglycemia. So as I said before, and I'll probably sound like a broken record by the end of this, that we really need to flip our thinking about diabetes when it comes to an older patient to be avoiding hypoglycemia instead of reducing hyperglycemia, which is the way we all think about diabetes in everyone who's less than 65, but we really need to flip the switch on that once they hit that magical age of 65. So let's jump into our first learning objective, which is management and goal setting. This comes from the ADA, and ACE has a very similar one. If you haven't seen it before, it basically gives you some modifiable and unmodifiable patient-specific factors, and gives you an idea of whether or not your A1C should be more strict or less strict. And I would say that the majority of us, when dealing with non-older patients, focus our attention on established vascular complications, whether or not they've had a previous heart attack or stroke, other comorbidities like they've had an amputation or they have retinopathy or neuropathy or something like that. And I would challenge you when you're thinking about older patients to not worry about those two anymore. Again, flipping it and really diving into the top three. So the risks associated with hypoglycemia, how long they've had the disease, because that will put them at increased risk for a lot of the things that we're going to talk about. And then certainly their life expectancy. So we use age 65 as sort of the cutoff, right, to put you in this older patient category. But it's really up to the clinician to look at that patient and have a good sense of what their life expectancy is going to be. We all probably have in our careers seen the 67-year-old patient that looks and acts 80 years old. And we've seen the 80-year-old patient that looks and acts like a 67-year-old. And not just visually, but on paper too, based on all of their diseases and their problem list and the medications that they take. And so it's really important for us to consider that life expectancy. You know, you might be working with a 75-year-old who, in fact, I have one of these patients. He's actually 82, I think. And he sounds like he's 60 when I talk to him on the phone. And he always tells me about how his parents lived into their hundreds. And so he expects to live into his hundreds. So he's 82, but he's a real young 82, and he's got some years ahead of him, right? And I'm sure we've all talked to the person on the opposite end of that spectrum. So these are some things that we really should be thinking about more holistically. There's new terminology buzzing around in the education world called person-centered care. So many of us have grown up in the era of patient-centered care, but this would be thinking of the whole person with everyone around them, including anyone that lives with them, anyone they may take care of, and also considering the things on this list too. So this was an interesting study that's actually alluded to in the ADA standards of care. So let me just orient you a little bit surrounding this. So what we know going into this study is general life expectancy for patients, or maybe we don't all know this, but generally a man at the age of 65 has about 18 more years of life left. And generally a female at the age of 65 has 20 more years of life, generally, obviously. So with that knowledge, Griffith and his colleagues here wanted to look at factors that might help predict 5 and 10-year mortality. And so they did just that, looking at different risk scores or risk factors. And so the left-hand side is the 5-year mortality, and the right-hand side is the 10-year mortality. And the bottom is the number of their risk score. This does exclude age, as you can see. And so what's interesting, and just to orient you a little bit about the study, is that the risk factors that they looked at, there were a lot of them. There were something like 30 for the 5-year mortality and like 36 for the 10-year mortality. But they really encompassed a lot of different things, right? Age and sex in terms of demographics. They did look at social determinants of health. They looked at healthcare utilization, different medications, different biomarkers, you know, BMI, serum creatinine, stuff like that, other comorbidities that they had. And so what they found basically is that they were able to predict a 50% chance of 5-year mortality if your score was greater than 22, and a 50% chance of a 10-year mortality if your score was greater than 14. Now, this is really cool in theory, but nobody's really going to use this in practice. There are too many questions. There's too much data to gather for every single patient for it to be worthwhile, right? It's not like a couple of questions that we ask when we're trying to figure out Ascbd risk score, right? We're talking about up to 36 questions to figure out someone's 10-year risk. So this is something that is more used like in clinical trials, but I just thought it was interesting to look at since we're talking about older patients and their true predicted chance of mortality, the more things they have going on. So let's talk about treatment goals in older patients and how they really should be stratified based on their health status. So we have different categories like A1C, fasting glucose, and bedtime glucose. So let's dive into someone's health status. ADA talks about a healthy patient. So this is somebody with few comorbidities, their functional status and cognition is intact. They recommend keeping the A1C goal pretty much close to everyone else's goal, less than 7.5, and keeping fasting and bedtime glucose pretty much the same as what we tell the rest of the population. Totally makes sense. And then we step it up a notch to our more intermediate or complex patients who have multiple comorbidities, or they have 2 or more instrumental ADL impairments. So these are things like, having trouble managing your medications or your finances. Maybe they're not driving anymore or shouldn't be driving, having trouble grooming themselves. There's a whole list of these ADLs. Or they might have mild or moderate cognitive impairment. And when somebody falls into this category, we really want to pull back on that A1C goal, again, in an effort to avoid hypoglycemia. But you can see that the fasting glucose goals jump up to 90 to 150, and bedtime jumps up. You don't want it any lower than 100. And then in our patients who are very complex and in poor health, these are your patients who are in long-term care facilities, have end-stage chronic diseases of any type, or have moderate to severe cognitive impairment, or they have these ADL impairments. Really, at that point, you shouldn't even be considering A1C. And potentially, luckily enough, at least in the ambulatory care world, we are held to some standards like CMS guidelines and HEDIS measures. And however, those stop taking effect once you are 75. So we don't have to worry about A1Cs in our patients who are older than 75. So that's great in terms of that, so that we can pull back on some of these goals. And then you can see also how fasting and bedtime really ramp up. And I really do use this in practice in my older patients. I really just say, look, I never want you less than 100 and I never want you over 200. So as long as you stay within that parameter, you're doing a great job. And that tends to work out pretty well. Additionally, it should be noted that A1Cs tend to be less accurate in older patients because conditions that are associated with increased red blood cell turnover, such as being on hemodialysis, some type of recent blood loss or transfusion, or being on erythropoietin. These are all things that are commonly seen in older adults, and they can falsely increase or decrease A1C. And it should also be noted, if you don't already know, that A1Cs are falsely low in Blacks as well, of all ages. So instead of relying on A1Cs, we can better interpret our treatment goals for really all patients, but we're talking about older patients tonight, through something called an AGP report, or an ambulatory glucose profile. I don't know how many of you out there have seen this or heard of this, so I'm just going to walk you through it a little bit so you have a decent understanding. And it allows us to not have to rely on A1C as much as we used to get an idea of what's happening with patients, while at the same time, it allows us to get very specific information from a patient so that we can make treatment decisions. So the report basically has 3 sections. The first is time in range, which is set universally at 70 to 180. So obviously for an older patient, this works out okay, except that 70 is a little low in my opinion. And for our not older patients, it's still a pretty wide range, and the 180 is a little high, but this report is meant to be universal. And so we just keep it like that. Now, once you pull down these reports, you can change those numbers, but the way a typical AGP is spit out, it's set at these rates. It does default to 14 days, but you can change that if you want to. And so you can see what's nice about these reports is that it gives you all the information there. There's no reason that you have to like memorize any of this, but you know, you don't want someone's blood glucose to be very high, which is over 250, more than 5% of the time. And high is considered between 180 and 250, and you'd like that to be less than 25% of the time. And you'd like them to be in target, that's 70, 180, more than 70% of the time, and so on and so forth. You can read what's on the screen there for you. It does give you some other interesting information. The GMI is basically an estimation of what their A1C will be if they were to take it today based on this data. So that's a nice estimator, especially if you are dealing with someone whose A1C isn't totally accurate. In other words, you have someone on hemodialysis and you know the A1C won't be accurate. You're looking at this and making some estimations, but you get the A1C and it's like, you know, 6. So you know that that's not accurate. The glucose variability is actually a really important number to look at. It's basically letting you know how much their sugars are low and high. And you don't want that variability. And so we're looking for that number to be less than 36%. And so when you see it high, like in this report here, that means you really have some work ahead of you to try and straighten that out, to get them out of the lows and get them out of the highs. So it's a little bit more of a flat line, like you'll see in the next slide. One last thing to mention here, if you have someone using a Libre, on their Libre device, time in range is actually called time in target. I have no idea why they did that. It's super confusing for everyone, but that's what it's called on there. So if you're working with somebody and you're looking for time in range, you won't find it. You'll find time in target, but it's the same thing. And what's nice about this is that if you can get someone to 70% time in range, their A1C will be about 7%. The next part of the graph is the actual profile. It's a nice little chart that for the amount of time you put in, 14 days, whatever, gives you a visual look by time of day starting at midnight. And so you can very easily see here that, yes, this patient is having wide fluctuations, but they do tend to go low overnight. So that would be something you'd want to address, and they go high in the evening. And then hopefully you can address that with the medications that they're taking and sort of straighten that graph out. And the last part of that AGP report is the daily profile. So it breaks it down by day of the week, as you can see there, and it puts each week on top of each other. And I like to look at this in terms of looking for trends on work days and not work days. Again, that's different for every patient, but if you just think about Saturday, Sunday, for most of us, people do tend to live their lives differently when they're working versus not working. And so you might be able to find some trends that work. There's nothing on this particular one, but I have caught a lot of things by looking at it in this particular manner, which is nice. Okay, so that's enough of the goals and AGP report. Another significant part of managing diabetes is going to be lifestyle management, and I won't spend a lot of time here because it's not the focus, but it does deserve some discussion because it is such a large part of dealing with patients who have diabetes. One thing I think that is important for all patients, but especially our older patients, is to ensure optimal nutrition and protein intake. This is something that is a pretty decent problem in our older patients. They aren't hungry, so they don't eat as much. Maybe they don't have the finances to eat as much, and they certainly then opt for cheaper foods, which tend to have less protein. I'm going to put a plug in here for Meals on Wheels. If you have any patients who are having issues with food or nutrition, they're a wonderful source that you should get them hooked up with if they aren't already. But the bottom line here is that if they don't have good nutrition their protein isn't high enough, it does actually increase their risk for frailty and sarcopenia. And this is where they're going to start to lose skeletal muscle mass and strength. And that's something we definitely don't want to have our older patients having to deal with. If they can regularly exercise, they should, and their recommendations wouldn't be any different than anyone else, except just to know their limits, right? Weight-bearing exercise, resistance training is still the best way to exercise when it comes to diabetes, because you want to get your muscles moving and get that glucose out of the system. And then for patients who are overweight or obese, we do still encourage modest weight loss. And luckily, we have a lot of good medications on the market now that can help patients do that without much lifestyle intervention, especially if they have physical ailments that won't allow them to do that. So if we move then into pharmacological therapy, everything that I talk about from this point forward, I want you to take within the context of these 3 guiding principles come from ADA standards of care. The first is choose medications with a low risk of hypoglycemia. The second is to de-intensify and simplify regimens to reduce the risk of hypoglycemia. And then the third is to consider cost and insurance coverage to avoid non-adherence. I would say a third of the triages and phone calls and emails that we get every day at my clinic are related to A1C is high because the patient is not adherent because they can't afford it, because their deductible is too high, they're in the donut hole, whatever. So these are real life challenges that a lot of us deal with every day with our patients. So you've seen this already. Caitlyn showed this to us earlier, and I'm going to focus in on the minimizing hypoglycemia section of that chart. And we're going to go through all of these. So medications that have no low risk of hypoglycemia, we're going to talk through those and give some advantages and disadvantages. And then we're going to talk through the moderate risk of hypoglycemia medications as well. So we have a full, clear picture of what's good and what's not so good and what we should avoid and not avoid. Okay, so let's start with our DPP-4 inhibitors, dipeptidopeptidase inhibitors. Our medication options for those are listed on the right-hand side of the page. And so good things about these medications are that they do have a low risk of hypoglycemia, and they do have very few side effects. The downside of these medications are they are brand name medications and very costly. They also actually don't have any of the Ascbd risk benefit that our other medications have that Caitlyn already reviewed. And their efficacy is considered intermediate with an average A1C lowering of about 0.75%. So that's not great. In the world of all the agents that we have, so many more have high efficacy. And so it's an option because of the low hypoglycemic risk. And if you've, have a patient that is on multiple therapies and has an A1C of 8 and you're trying to get them to 7.5 and, can't use a bunch of other things, and this is your one of the last options, then, it's going to get them and it's a goal and it's not going to cause them hypoglycemia. So it's worth a shot. The GLP-1 receptor agonists, you can see our options on the right-hand side there, already reviewed by Caitlyn. And I've denoted the ones that have the Ascbd benefit and the CKD benefit, or DKD, same difference. Here you see a lot more green thumbs, right? So low risk of hypoglycemia. They do have the Ascbd benefit. It does slow the progression. does have the weight loss, but they are still costly. They do have significant side effects, most notably GI. They are injectable, which can be a burden for some patients, but their efficacy is high and they have pretty decent A1C lowering. So these are definitely an option for you to consider in older patients. Although not in the ADA guidelines per se, I thought I would be remiss if I didn't throw in our new friend tirzepatide. As of right now, it does have low risk of hypoglycemia. In the SURPASS trial, there were no level 2 or level 3 hypoglycemic reactions. So that's basically like blood glucose is less than 54 or having to seek help, call 911 or get to the ER. However, we don't know really about ASCVD benefit or slowing CKD progression as of yet. So we'll wait on those. We do know that it has significant weight loss and probably the best in class, meaning better than the GLP-1s alone. Although there's no, actually there is a head-to-head, I believe. Yeah, so they did show that. They are costly, obviously, because they're brand new out. And frankly, at this point, they're not even on some formularies. So it would require a prior auth right out of the gate if you were to try and recommend if a clinician was going to prescribe this. Like tomorrow, most likely it would require a prior auth to get it. But my experience is showing, at least in the Western New York area where I am in Buffalo, that they're all getting approved. It's just that extra step. Significant GI side effects, and it is injectable, of course, but the highest in all of the diabetes medications in terms of A1C lowering. It should be noted when you put either this medication, tirzepatide, or the GLP-1s, well, really all medications, but these were studied in SURPASS, that if you put them with basal insulin or sulfonylureas, then the hypoglycemic rate raises to like 15%. It's something really crazy. So probably more to do with the additional medication than this, but when in combination, you can't forget about it. Our next classes are biguanides. There's only one in class. It's metformin. A lot of green thumbs here. Definitely a low risk of hypo. There's some mild weight loss. It is very cheap. It is the, first line therapy of both guidelines. But it does have significant GI effects, which gives it a red thumbs down, but it does have high efficacy in terms of its A1C lowering capability. Things to consider about metformin: ER is definitely better tolerated than IR. Long-term use of metformin, you're going to want to start thinking about B12 deficiency, so you'll want to start pulling that. And a quick note about cost, if you're unaware, while we do have these other dosage forms like the modified release or the MOD, and then we have the osmolar, the OSM, the osmotic layer drilled. These are really, really expensive. And so they were brought to market in hopes that they would be better tolerated in terms of the GI side effects. And frankly, they are, but not at the cost of them. I mean, like thousands of dollars for a month's supply of metformin just seems outrageous when you can get regular ER metformin for like $5. I have Fortimet crossed out because as a brand name, it's been discontinued in the States. But you can still get that generic version. So just something to think about and consider when you're dealing with metformin. And then we have our SGLT2s. Again, the agents are listed on the right-hand side, already reviewed tonight. I've denoted which ones have the Ascbd, CKD, and then heart failure benefit. Lots of green thumbs on this one, which is great. Has the low risk of hypo, has the Ascbd benefit, has the heart failure benefit. It slows the progression. It has some modest weight loss, but they are brand name medications, which are costly. There are numerous side effects, but I almost put a green thumb next to this as well, because they are mostly manageable in my opinion, but Caitlyn did review them thoroughly, and certainly there are definite risk factors that can put you at significant risk. And so you really have to do a lot of education when considering an Sglt2 inhibitor. And they are considered intermediate in terms of their efficacy. And you can see the A1C lowering listed there. And then we move into thiazolidinediones, or TZDs. And I do not want you to be afraid of these medications. Actually, in my clinic, we use them a lot. And frankly, endocrinologists use them a lot because they are, well, really the one that we use, pioglitazone, is a great tool in our toolbox and works very well. As you can see there, the efficacy is considered high, but it's not without its problems, right? So there are two options available, rosiglitazone and pioglitazone. It is my understanding that Rosie's, Avandia you really can't get anymore, and Rosie is fading away, but it's still showing as on the market. I have it crossed out because you shouldn't be, and nobody should be on this anymore. If they require a TZD, they really should be on the pioglitazone. Is a safer drug, and there's no reason at all for someone to choose Rosie over Pio, given their side effect profiles. But they have a low risk of hypoglycemia. They are very cheap, but they don't have any of those extra benefits that our GLP-1s and SGLT2s, and even metformin has some of these. I have an up and down thumbs on the weight gain because it is a real thing that patients are likely going to gain weight, but not everyone will. I do have patients who I've put on TZD and haven't really gained that much weight. You do have to watch out for a bunch of things. You have to think about heart failure, use in heart failure. You're not going to use it, it's contraindicated. Patients who have osteoporosis, puts them at increased risk for falls and fractures, macular edema. There's a whole host of things you need to think about. Bladder cancer in particular with PO. So it's not without its issues, but that doesn't mean you should just cross it off of your diabetes arsenal list. There's even been some studies that looked at pioglitazone in patients with NASH, non-alcoholic steatohepatitis, and had some benefit. There's also been some studies that tried to show that it had Ascbd benefit, but then there's plenty of studies that show that it doesn't. So I don't want to really say the jury is still out on that. I think it's pretty definitive that it doesn't have any Ascbd benefit. Now let's move into the medications that are in our sort of moderate intermediate risk of causing low blood sugar. And these are the ones that you should pause and think about using or not using in your older patient population. The other ones that I talked about already are the ones that you don't even have to give a second look to. Just if it's appropriate for them, use it. It's not going to cause any hypo, but these next two will, and you should really consider using or not using. So insulin secretagogues. This includes our second generation sulfonylureas, glyburide, glipizide, glimepiride, and the meglitinides, nitaglinide and repaglinide. Both of those brand name products are no longer available in the US, just generically. It should be noted that sort of in pecking order of efficacy, glyburide is your most potent sulfonylurea, then glimepiride, and then glipizide, which is likely why glyburide and glimepiride have a Beers list categorization and the glipizide does not. So in our older patients, if they can't afford anything and need something cheap, glipizide is not a bad option, but you have to look at them, the entire picture and see, do they live with somebody? Can they deal with lows? Is there anything else you can consider de-intensifying to make sure that they're not having lows? So while they are cheap, they don't have any of these extra added ASCVD, heart failure, kidney benefits. They are likely going to have some weight gain, but the meglitinides tend not to really have that weight gain. It's the sulfonylureas that are going to have that weight gain. And just a reminder, if everyone isn't clear, the meglitinides are what we consider short-acting sulfonylureas. So they work to wake up your pancreas and produce insulin, but on a short-term basis. So you take these pills every time that you eat. Your sugar goes up while you eat. This med should kick in just for a couple of hours, make a little bit of insulin, cover that food, and then you can move on with the day. So there's a way less risk of hypoglycemia with the meglitinides, and also way less weight gain with the meglitinides. So these are sort of my go-to, actually, if I'm thinking about adding something on. But they have pretty good A1C efficacy at almost upwards of 2%, but not the meglitinides. Those are definitely closer to the 1% mark. And then basal insulin is another that is likely to cause some hypoglycemia. I've listed our long-acting analogs there on the right-hand side. So insulin glargine comes as Lantus, Toujeo, Basaglar. Then we have our biosimilar glargine, which is known as Semglee. And then we have insulin detamir and insulin degludec. And I'd like to take a moment just to talk through the differences between basically our three different options here: glargine, detamir, degludec. We obviously also have NPH. It's technically considered, in the world of insulin, it's considered a basal insulin. But if you are trying to avoid hypoglycemia, NPH is not the way to do it. Now, there might be some cost issues that require you to use NPH, but mostly those now have been mitigated with the passage of that new, I don't know if it's a law or a mandate or whatever, but basically our insulin shouldn't cost a diabetic any more than $35 a month. And so that does really help the affordability of these. I remember 10 years ago, I used to, by the end of the year, patients who were in the donut hole, I used to take them off their Lantus and put them on NPH for, October, November, December, and then flip them back in January because that's all that they could afford. But that's really no longer the case. So what's really kind of exciting in the world of basal insulin was the introduction of insulin degludec, because it just worked so differently than the other two that we had on the market previously, the detamir and the glargine. It takes such a long time for it to be broken down that it actually has a steady state. And none of the other insulins have this. So a patient could double up on dose, which we know can easily happen if you're an older patient and have some mild cognitive impairment. You could easily take it late, in fact, up to 3 days late. You could forget it for a couple of days, and you'd still be at that same steady state level of insulin, which is really unique, because if you did that with any of the other basal insulins, they'd be out of your body at the end of the 24 hours. So it has like a half-life of 25 hours. It has a duration of action of 42 hours. But it was so cool about it is that it doesn't cause any stacking of insulin and does not put the patient at an increased risk for hypoglycemia. even if they double a dose, right? So they forgot they took it last night and they take it again the next morning. There's no insulin stacking happening there, and there's no increased risk of hypoglycemia. It's unique in its structure in that it is made up of these multi-hexamers, which are just like super tightly bound and take a really long time to get broken down once they've been injected, and they form like a little depot under your skin. And then once they are broken down, they like albumin, so they attach onto the albumin for a little bit, and then they go off and do their work. So it's a really unique molecule that would be my go-to, is my go-to in older patients. If it's covered on their insurance, I prefer Tresiba or insulin degludec over the others. If you happen to be using the other insulins, a dosing tip I can give you is to just swap when they take the insulin if they're having issues. So a lot of times what I see is patients have been told they need to take their basal insulin at night. Now, this is how Lantus was introduced to the world however many years ago, 30 years ago, probably now, that you should take bedtime insulin, and you should take these basal insulins at bedtime. There's no rhyme or reason to doing that. You don't need to take them at bedtime because these long-acting insulin analogs have a pretty flat curve when there's really no curve. And so it doesn't matter what time of day you take them, right? But people are still stuck on this, and clinicians are still stuck on this. So they tell them to take it at night. And then what you find is that their fasting sugars are, dipping a little low. They're at 90, they're less than 100. But then the rest of the day they run high. They're close to 200, 180, 200, 220, stuff like that. If that's the case, you just flip it and you say, take it in the morning, and it'll give them more coverage during the day, and hopefully back up on those fasting so they're not as low in the morning. So that's a tip that you can use if you're seeing that with patients. And then the obvious elephant in the room here is bolus insulin, and where does that fit? I'm not even going to talk about it because that has like the highest risk for hypoglycemia and really should be avoided at all costs if you can in our older population. You're certainly going to have a cohort of your type 1s who are going to be on it, right? And you just have to keep a real close eye on them. Hopefully they're on some kind of CGM that can alert them or predict for them. Ideally a pump, but that's a whole other lecture and harder to get in our Medicare population. So that's enough about management. Let's move into cardiovascular risk modification. And I am talking a lot, so let's speed this up. Sorry, I tend to do this. So cardiovascular treatment goals in older adults. We've got blood pressure goals and lipid goals, and it's the same health status that we saw earlier. So healthy, we say we can back off on blood pressure a little bit, but you should still use a statin as long as it's not contraindicated and it is tolerable. Complex or intermediate, same blood pressure goal. It's not until we get to our very complex patients that we can pull back on our blood pressure goal even more. And this is the area where the benefit of the statin probably isn't there given their life expectancy at that point. Hypertension in management, as already stated, you want to relax the blood pressure goals, and you're going to want to rely on the agents that aren't going to cause hypotension as much. So you want to focus on thiazides, ACEs and ARBs, and calcium channel blockers. And any good pharmacist will give you this advice: confirm adherence before adding additional therapy or increasing doses. You'll also want to closely monitor sodium, potassium, and renal function. You might have patients come in complaining of confusion, headache, nausea. That might not actually be their blood pressure. It could be that their levels are off. It could be hyponatremic. So you'll want to just make sure that you're fixing the real problem, underlying issue if there is one. Obviously, these are things that we tell a lot of people, make sure that they stay hydrated. And there was a chronotherapy study done that basically confirmed that you get better blood pressure control if you take one of your medications at bedtime and the rest in the morning. We've always been taught that you should take your blood pressure pills in the morning, but this study did show better at least one at bedtime. So depending on how many they are on, you might end up putting 2 at bedtime, but at least one of them should be at bedtime. So that's a little tip for blood pressure management in anyone, not just older patients. Obviously, we're going to want to avoid the medications that are on the Beers list. I probably don't need to spend too much time here. All of this is information that we all know. Alpha blockers should be avoided because of the orthostatic hypotension. If creatinine clearance is less than 30, there are certain medications you'll want to avoid, et cetera, et cetera. So that's just a listing here for you on those medications. Let's move into lipid management. This certainly is a hot topic. A lot of patients have many strong opinions about the use of statins. And so let's talk about that. There's definitely some evidence, but there are some associated considerations, as you can see here. Is the cost effectiveness there for an older patient? Is there some disability or competing risk assessment you need to think about? Are the muscle symptoms more apparent in our older patients? So there definitely is a lack of robust evidence surrounding statins in older patients, but I was able to pull a few, and there's just a summary of them here. So the Prosper trial looked at pravastatin, and you can see the age ranges there. And these were in patients who did not have baseline Ascbd. And what they did find some benefit. They saw a decrease in LDL, they saw a decrease in MI and CVD death, but no stroke reduction benefit out of that one. Then Ritker and colleagues did a study. They did like a post hoc analysis of patients in the Jupiter and Hope 3. So this was looking at rosuvastatin, also no baseline Ascbd. And it did decrease composite outcomes by 26% compared with placebo. And these were patients over the age of 70. So they pulled those older patients out. Orkabee et al. This one looked at all statins, but it was just in US veterans. The average age was 81 years old, no Ascbd at baseline, and it did show a decrease in all cause. And then finally, Zhao looked at the study data from Aspirin, which was, the aspirin trial, pulled out the patients greater than 70, no Ascbd at baseline. And this was interesting. It was trying to see if patients could live a more disability-free life. It did not show that. But it did show some decrease in physical disabilities, however. And so really the jury is still out on this. There are some other studies ongoing, Preventable and STARI, that one's due first in 2023. That might help us answer some of these unanswered questions. And how beneficial is a statin if you had to start one in someone who's 70 years old who hasn't been on one yet? Or how beneficial is it to keep it on in someone who's 80 years old? These are questions we don't have a lot of answers to yet. So in terms of using a statin, we do have some numbers, and we do know that it can help our patients. So you can see here that after 4 years, in about 255 patients, 1 case of new diabetes diagnosis, but 5 vascular events are avoided. So we talk, you probably talk to patients who don't want to be on statins. They say they don't want to be on it because it's going to cause diabetes. Well, here's the news. The truth is it could, but not in that many people. And what it's preventing is worth the risk of what it might be causing. And cognitive function, we hear a lot about that, but none of the studies have shown that. So In terms of aspirin use, this is one of the most controversial topics, right? Patients using aspirin, who should be on it, who should not be on it, what dose, etc. Recommendations from ADA have recently changed, and it is generally not recommended for greater than 70 years old for primary prevention, and that was based on the Ascbd trial because there was risk of major bleed. The USP-STF did change the recommendations a few years ago, so we're not using aspirin for primary prevention in patients greater than 60 years old anymore. Now let's jump through hypoglycemia. Let's see if we can get through this fast. I apologize. So we want to assess hypoglycemic risk in by looking at a lot of these things, right? How old are they? How long have they had diabetes? Are they on a lot of medications? Is their food intake unpredictable? All the kinds of things that you would think about normally, I think. What you need to think about, and let this sink in for a second, severe hypoglycemia is associated with reduced cognitive function. So if somebody is repeatedly having severe low blood sugars, it will cause reduced cognitive function. However, patients with cognitive function have more severe hypoglycemia. So it turns into this cycle, this never-ending cycle. This is how ADA classifies low blood sugar as a level 1, 2, 3. Less than 70, less than 54. That's what I alluded to earlier. Everybody knows signs and symptoms of hypoglycemia. So this was just really here for completion's sake. All of us also mostly know about these other medications that we need to think about, right? So beta blockers, we all know, of course, are going to blunt, especially the non-cardioselective, are going to blunt that adrenergic response and make potentially someone hypoglycemic unaware. SSRIs are going to alter the perception of those low blood sugar symptoms. ACEs are still a little controversial. Some studies say that it causes low, some say that it causes high, and some say nothing. So the jury's still out on that one. We all are pretty familiar with quinolone antibiotics. Tramadol is maybe a newer one. It was a rather newer study in JAMA that looked at, and that showed a 52% increased risk. So this was not causality. I don't want you to panic about this one, but it just showed an association. So, and then quinine is another one as well, although we don't see that one as much anymore. So how do we treat low blood sugar? The rule of 15. Most of us have probably heard of this. Check with a finger stick, eat 15 grams of carb, wait 15 minutes. 15 grams of carb are listed here. What would be considered 15 grams of carb? And what you do need to remember is that anyone is taking a drug called acarbose or Precose, they need to use a very specific type of sugar. So it has to be glucose tablets because the drug itself is going to make any other type of sugar. It's going to break it down, and it's not going to help raise the blood sugar. So these are our options. We have a lot of them now. We've got glucagon, we've got Dazzy Glucagon, we've got auto injectors, pre-filled syringes. They all basically do the same thing. It's just a matter of maybe what's covered and what's easier or more comfortable for a patient. I'm not sure very many people are giving out the glucagon hypo kit anymore because it does take some dexterity to put together, but it is still available. We have to dilute it. Then we have Baqsimi, which is the powder that we can use as an inhaler. And what's nice about this is that you actually don't have to inhale it. So somebody can be unconscious and you can just use it and it sits and gets absorbed through the nasal passages. And so that's a nice option for many patients, the easiest one to use, I would say, of all of them, but it will take a little bit longer to work. And then we have Voc Hypopen. And so this is a nice pre-filled auto injector, comes in doses for kids and adults and comes with 2 pens. So you have a backup if you need it. All of them basically do. And then you have the Gvoc pre-filled syringe. So this is just sort of patient preference and what they might be used to. And then we have the Dazzy Glucagon, and that comes as an auto injector as well. And so pretty much the same as the rest of them. This one just tends to work, is a little bit more stable the way that they made it, and tends to work just a tad bit faster than the regular glucagon. And then same idea, does have a pre-filled syringe as an option as well. So it's really just what the patient is comfortable with, or the caregiver likely is who's going to be using that. So who should use it? Patients who are at risk for that level 2 or level 3. All type 1 patients should have this at home. And if you're going to put an older patient on insulin or sulfonylurea, I would train them on how to use this. And then probably any older patients you have with that mild cognitive impairment, I'd have this available at home for them as well. And sorry, I went a little over. We probably don't have time for questions.
So thank you. So I think maybe we'll do one question about that. So I think we'll get the CE codes in here in a second. So what thoughts, if any of you have, in terms of dosing some of the long-acting insulins in patients with low albumin?
Oh, that's a good question. If you have someone with low albumin, then you should use Lantus or insulin glargine, one of those, because they don't depend on the albumin at all. You would want to avoid insulin detamir, because that definitely does. And the insulin degludec, to a lesser extent, will grab onto the albumin. I guess I'd have less concerns about the degludec, but if I had someone like that, I would definitely use insulin glargine.
All right, thank you. So I said some other ones. So we have the CE codes that for session 2 that are in the